Good evening. My name is Tricia Burning. I am the Chief Executive Director of Penn Medicine Development, and it's my honor to welcome everyone to tonight's Penn Medicine Insights event focused on opioid use disorder. Tonight's panel and program will certainly be informative and we hope inspirational. Before 2020, before anyone had ever heard of COVID-19, the opioid crisis gripped our country and was a top topic of the national dialogue. The COVID pandemic did not stop the opioid crisis, which continues to strike very close to home. Just in 2019 alone, 1,150 people died from drug overdoses in Philadelphia. 80% of those overdose deaths include opioids. We have the highest rate by far of overdose death among major United States cities. In 2018, more than 67,000 people overdosed in the United States. Nearly 70% of those deaths were opioid related. Before and certainly during the COVID pandemic, Penn Medicine has been working to combat the crisis on several fronts, and this evening you'll hear from several of our faculty leaders about how they are working to stem the tide of this terrible epidemic, to curb and reduce the rates of addiction and death as a result of the disorder, which has stolen too many minds, too many hearts, and too many lives from families in Philadelphia, the nation, and the world. And now, I am pleased to introduce tonight's moderator. We are so very fortunate to have Hallie Edelman with us this evening. Hallie is a proud member of the Penn Medicine family and has made major contributions to society as a citizen of Philadelphia and the world, as both an author and founder of World HA Productions. Hallie was an executive producer on The Social Dilemma, the acclaimed documentary about the perils of social media and the toll our increasingly online world is taking on young people. It gave me great pause about my own personal use of social media and certainly informs my decisions about that social media use of my children. Hallie's next major documentary film, entitled Our American Family, tackles the subject of generational addiction and makes her the perfect moderator for tonight's Penn Medicine conversation. Hallie Edelman is a PhD in education, has taught elementary school through university students, and has advocated for quality education and, importantly, mental health initiatives in many ways throughout her professional and personal pursuits. Welcome and thank you, Hallie, for serving Penn Medicine in Philadelphia in the capacity of moderator this evening. The event is all yours.
Thank you so much. It's really wonderful to be here with everybody. And Tricia, thank you for really grounding us in the important statistics. And hopefully we all recognize together tonight that this is not a disease based on statistics. This, as you mentioned, really does affect so many of our communities members and so many family members and beyond. And we are here together tonight to create this forum. Our goal, as Tricia said, is to start a conversation that will hopefully continue beyond tonight and to really uncover what our top Penn Med docs are seeing regarding the opioid epidemic and also what these exceptional docs are doing to create change, to best support patients, and to explore cutting-edge practices in the areas of responsible pain management and opioid use disorder. To give you a sense of the structure of tonight's event, we're going to hear from a little bit from each of our doctors individually. We can learn a little bit more about their work and what they're doing themselves and in groups. And then we're going to engage in a discussion with them to hopefully answer some of the questions that were sent in from the community. And then we will wrap up by taking a few questions from the chat. So feel free to put questions into the Q&A for a final roundtable at the end. Hopefully you'll also then receive resources for you if you have any additional questions or need points of contact if you want to either best support your family or your own practice, or if you'd like to get involved in some of the work being done here at Penn Medicine. So without further ado, I'm hoping to talk as little as possible so you can hear from the brilliance of our panelists. And I'd like to first start by sharing with you one of our great doctors, Dr. Kit Delgado. Dr. Delgado is an assistant professor of emergency medicine and epidemiology, and also an attending physician at Penn Presbyterian Medical Center Emergency Department. He is the director of Behavioral Science and Analytics for Brain Injury Reduction Lab, which applies data about preventing injuries and overdoses. And Dr. Delgado is also the co-chair of the Penn Medicine Opioid Task Force. Dr. Delgado, thank you so much for joining us tonight.
Thank you. It's great to be here.
So just to kind of jump right in together, from your work as an attending in the emergency department, you're in this unique position, right? You're treating people for both pain with opioids, and you're also treating people who are coming into the OR who have overdosed from prescription or illicit opioids. So we've heard about these, staggering statistics, and from your vantage point, from your unique vantage point, what is your opinion on prescription opioids? Should they be an option for patients at all?
Yeah, that's a great question, and just want to get this out of the way first. Opioids are an essential treatment for the treatment of severe pain, and particularly for pain that can't be controlled with other means, whether it's medication or other non-pharmaceutical medications. And it is true, when I have an ER shift, it's very common. I'll have one room, I'll have a patient with a back fracture, has very severe pain. In another room, I'll have someone who just overdosed, fortunately very common right now, or come in with an abscess from injecting the heroin into their forearm. And so we need to sort of balance this. And I think in the emergency department, I think we became acutely aware of sort of the tension between how can we provide effective pain management, but also be mindful of the harms. And so there's no doubt that opioids can provide effective pain management for very severe pain, but we also do know that the more pills we write for someone that's never gotten an opioid prescription, the higher likelihood that they transition to using opioids chronically or developing an opioid use disorder. We know that the more pills that are given to patients, the higher likelihood it is that their child or their teenager overdoses. And we also know that after common surgical procedures, a large number of these pills are left over. So I think that the goal is not to reduce opioid prescribing completely. It's being careful stewards of opioids, prescribing when they're clinically indicated, and right-sizing pain management in a patient-centered way, so that we give opioids to patients who need it, but we don't excessively prescribe it willy-nilly.
It's amazing too, because when we had spoken before, you told me that about 7 to 10 years ago, ER docs were some of the first docs to recognize just how many, opioids were being prescribed and getting into the hands of families, and then eventually maybe even of their children, and, so on. And I know you're a thought leader in how to figure out this balance, or how can we create some sort of guideline to look at the number of opioids being prescribed. So can you talk to us a little bit about what you've started to do to explore this overprescription problem that's been identified?
Sure, yeah, absolutely. And I have to also mention my colleague, Dr. Perrone, too, is really a national leader. When we were seeing the increasing number of overdoses, starting 2010, she was really at the forefront in identifying this. But we in the emergency department were among the first to develop guidelines, best evidence guidelines for how to prescribe opioids for acute pain. And then we also, in our Penn Medicine, we incorporated those right into our electronic medical record orders. And we found that when we made the easy thing to do also the guideline way to prescribe opioids, everyone started following the guidelines. When I went as in my role in the opioid task force, and I reached out to some of our surgical colleagues, and I said, we we've had good success in the emergency department implementing guidelines for prescribing for 10, 12 pills for most indications. They said, that all sounds great, but I'm worried about my patients having uncontrolled pain. How do I know that if we cut down on opioids for routine post-operative prescriptions, how is this going to affect them? So in collaboration with some of our orthopedic surgeons, we set up a pilot where I had my research assistant call their patients after knee arthroscopies, which are one of the most common procedures done in the country. It's an outpatient procedure. And at baseline, patients were being prescribed anywhere between 30 and 50 pills. And what we found out when we called them, that actually 1/3 took none, and the vast majority took under 10, 95%. We showed them the data, and they said, "Whoa, this is really eye-opening," and that it gave them the confidence to reduce their prescribing. So what we did in Penn Medicine with funding from the FDA and support from the task force, we now created a system where we can text patients after surgery through recreating what my research coordinator was able to do. We now had this started with orthopedics and then moved on to urology and neurosurgery, and now scaling this up throughout the health system. And now we can get in real time data on how many opioids patients need on average, and then tailor prescribing according to those to that data, so that we're capturing most of what people need, make it easy to get refills for people that need more, but we're not overprescribing 30, 40 pills for something that may require just 5 pills after surgery.
It's amazing. And what is your goal for distributing these guidelines or getting this information to more people or making sure more doctors can access this information?
Sure. I mean, for right now, we just published some of this initial work in New England Journal of Medicine Catalyst and JAMA Network Open on some of our own data, which has gotten some traction and is being used to develop guidelines and pointing out, for example, nationally, we know on average 40 pills are prescribed for knee arthroscopy, and we're finding that 10 pills would cover 95% of patients' needs, and getting that out there. But what we're aiming to do is, now that we're collecting all these data, putting it on a website where we can, by every procedure, group procedures by severity, make it, very clear for orthopedists, urologists, whatever kind of surgery. Here are the guidelines that we've developed for prescribing. And what we'd eventually like to do is open up this system to other health systems and other entities that want to get insight on how to manage pain in their patients. Allow them to tap into the system so that they can improve their opioid stewardship.
And is that common for what you were seeing about 75% more pills were being prescribed than needed? Like, is that kind of what you were seeing a little bit?
Yeah, I mean, we found just in our own departments, but at baseline when we first started doing this, that across multiple departments, 60% of the pills that were being prescribed are actually not taken, and that when we did implemented these guidelines, and that the surgeons were prescribing according to the patient needs, we were able to reduce the number of pills prescribed by over 50%. But importantly, we tracked how could they manage their pain, and it was the same or better because we were starting to use more acetaminophen and ibuprofen. The refill rates remained the same, and the most important thing was that the surgeons say, "Hey, I haven't gotten any more phone calls about this," and so we've actually gotten some thank you messages from patients saying that they appreciated that we're being careful about this.
Yeah, great. Well, I'm excited because we also get to talk to your co-chair from the Opioid Task Force. So I'd love to also introduce Tanya Uretsky, Dr. Delgado's co-chair of the Penn Medicine Opioid Task Force. You'll see her in a moment, and she's a clinical pharmacy specialist in opioid stewardship at the Hospital of the University of Pennsylvania. She's a founding member of the Palliative Care Service, And in 2020, Dr. Uritsky received the Pennsylvania Society of Health System Pharmacist Joe E. Smith Award for excellence in practice and service to the community and pharmacy profession. So Dr. Uritsky, thanks so much for joining us.
Hey there, I'm happy to be here. This is a great opportunity, so thank you.
Yeah, it was really great to hear not just about your work with Dr. Delgado, but you also had this unique perspective, kind of, starting your career in pain management and palliative care, and then to supporting patients with opioid use disorder. So based on your experiences, how can doctors keep their patients safe, while optimizing pain management with opioids? And,
Sure,
and what alternatives for pain management exist? Is opioid our only option here? So kind of two questions.
Yeah, absolutely. Thank you. Yeah, so my background a lot came out of palliative care, but that holistic approach to anybody with a serious illness is what I like to bring forward when I'm caring for any of my patients. If you have something that needs to be tended to, we should be thinking about it from all aspects. And I think that is part of the safety, in the equation, is thinking through the entire picture. And we have certain tools that we can use. One of those tools is like a screening tool, right? Screening for risk of harms from the opioids, because the patients aren't the risky people. It's the medicine, right? The medicine has its own risks. And so we can screen for what those risks can do, and we can help talk with the patient, which gets to the next kind of safety part of the equation, is that therapeutic relationship. So using that to talk with the patients about the risks and benefits, and just educating patients about what we expect from the medications, that we're not expecting pain to go away, and like what do we expect these medications to do, not just from pain relief, but also from adverse effects and things that we're worried about and things we should monitor for, because the patient is their own best advocate, and we need to empower them to advocate for themselves. And so we can use these medications safely. And when patients do have, if they can safely use other medications, then we should absolutely be using as the backbone of our regimens things like acetaminophen, or the trade name Tylenol, which most people recognize, or ibuprofen or naproxen, which are non-steroidal medications. We should be using all the time. I like to describe it kind of like a cake. So your base of your cake is the acetaminophen and the ibuprofen, and then you put on top, you sprinkle on some opioids for the more severe pain that does not get controlled by those medications. So we can use our other medications, and it's not just those two medications. There's other things we can do as well that actually we need a prescription for. So we'd want to have the physicians or the providers, whoever's the practitioner prescribing those things. And so that's also an education session with the patient and discussing it to use that, or not just opioids. And then finally, if we are prescribing opioids, which patients do need that for pain control, we should be thinking about the role of the medication called Narcan or Naloxone, and having that in the home. So not, there's different takes on whether it should be in everyone's home, but I like to think of it as a fire extinguisher. You have it there for in the rare, hopefully never chance that you need it. And it's not something that means you have a problem or you don't have a problem, or, you just have a medication that carries a risk. And just like if you had insulin, you'd want to have sugar nearby. It's the same exact concept. And so we can keep people safer if we just have it around, just in case. And we can educate to that and help our patients and our families understand why we want them to have that.
So basically you're saying two things. One, you talked about screening patients in advance. Can you talk to us, what does that screening process look like? Is that asking somebody if they have addiction in their family? What does that screening look like?
So there are definitely tools you can use that, providers can use more standard. And it is about if there's risk, if there's a family history, it takes into account other specific risk factors, which I imagine some of the future coming speakers will speak to as well, being that they are definitely the experts in management of this disease state or of opiate use disorder. And so, there are standard tools that take into account things like your own. And then there's other things you can do to make sure that we are just kind of optimizing care. And for one of those things we can do is really set functional goals. and use our functional goals to assess how we're proceeding and how we're managing with our pain management. If we're not achieving our functional goals, why is that? Is it the right medication? Is it the right dose? What other, are we using physical therapy? What other things are we doing? And like when I say functional goal, maybe your goal might just be to make dinner 5 nights a week, or to take a walk around the block, or just something that's realistic for the patient, and assess our progress towards that, not just a pain number or, something that we can't really assess that well.
I actually really love that you had told me that, because when I had asked you, how can patients feel comfortable taking some of these medications? And you said, we really are hoping with these medications, if someone's dealing with chronic pain, that they're going to function better. So if they're not functioning better, like that's just a huge flag. And, that's one of the things that doctors and patients need to consider. Where are you headed once you're taking this med? Absolutely. You also mentioned Narcan. That if you're being prescribed an opioid, you should also perhaps ask for, or the doctor should offer, a prescription of Narcan. For people who don't know that are here tonight, can you just share what Narcan is?
Absolutely. Thank you. So Narcan is what we use to reverse an opioid. If we get a little too much opioid for whatever reason, they may not have intended that. That can happen because, again, these medicines carry that risk of making people sleepy and potentially affecting their breathing. Narcan can very, very quickly reverse that and can help save a life. And that's the underlying message here. Whether, however you got too much medicine, it can save a life. And that's the key to Narcan. So just by reversing the effects of the opioid medication on the person's breathing.
Thank you. And are there dangers? So now that if your patient is prescribed an opioid and you're, concerned in some way, you've flagged this function thing, are there other pieces that as a practitioner you'll look for when you're prescribing opioids to patients that appear to be a danger sign to you?
For me, it's really, there are people will flag behaviors, right? Certain things like, you're refilling more often or too soon. You have multiple prescribers, things like that. And again, for me, it also just comes back to function. When the risk outweighs the benefit, like, are we not making you better? And regardless of what your behavior is, if we're making you worse, if we're not improving whatever the complaint is, then we should be talking about that. It's not a punitive thing. It's not your fault, right? It's just, this is an opportunity to talk about what else we can do. And even if you are refilling too soon or you're taking more than you're supposed to, we need to now stop and talk about it and figure out what's going on, and try and get you the help you need if that's what you need, or what else we should be doing.
And from your work with Dr. Delgado, it's so inspiring to think that there will be shifts, guidelines, people, doctors and at Penn Med are paying attention to what does judicious use or judicious prescribing look like. So we understand that from, your research and what Dr. Delgado shared with us, that there were so many pills being prescribed. And I know that you've talked to me about saying, how can we get these pills that were either overprescribed or pills that were left over then out of patients' hands, So can you talk to us a little bit about the disposal proposal that you've been also working on?
Sure, yeah. So working with Kit has been great, and he's been some really inspiring work. And what we know, like he said, is even when we cut down the pills, we're still only taking 60% of what we're given. So even if we only give 10, we still have 4 left over. And so where do they go? And they go into the community. And then we know that, that increases the risk of it getting in the hands of a person who's not intended for. And so we can provide packets to patients, little ketchup-like packets that you put into a vial of medication. You add some water, you shake it up, and it becomes basically non-usable. You throw it in your garbage. They recommend to dispose of medications that you use kitty litter or coffee. But I don't know about you. I don't have a cat and I don't drink coffee, so I don't know how to dispose of my medicine. It's the truth. And then the other thing is they tell you to flush it down the toilet, but I have a water well. I'm not flushing any medicine down into my precious water well. So what do I do with my medicine? So this packet helps you to actually give you a tool, and when we give people a tool to actually dispose of their medicine, they're 4 times more likely to do it. And so, in times of COVID, when we don't want to go out and we don't want to take our medicines to drop boxes, we do have drop boxes at every Penn Medicine pharmacy where you can return your medicines and dispose of them. You may be better off having a packet in your house where you just dissolve it in your pills and you pitch it in the garbage. Obviously take your personal information off of it. But so we're trying to send these packets to patients post-operatively and see if that doesn't improve the likelihood of disposal.
Great. Well, I'm also I know we're going to have more questions for you later, Dr. Uritsky.
Yeah.
And I'm really excited to also introduce Dr. Kyle Campman. I'm really excited because we've talked about responsible opioid prescribing. We've talked about disposing of them, mostly for patients who have been managing pain. But as Tricia said when we started this conversation, there are so many families that are being touched by the opioid epidemic. There are so many families that are wondering, what can they do at this moment in time? What types of treatments are available? What haven't they tried? What's being developed right now? And what are some of the answers to those controversial pieces of whether it's new medications that are being offered or new trials that are being offered? So hopefully this next section of our conversation will lead us to some of those answers. So Dr. Kyle Campman is a leading expert on opioid use disorder. His focus has been on developing medications that block the response of opioids in the brain. Dr. Campman is a professor in the Department of Psychiatry. He has extensive NIH-funded experience with clinical research in medications for cocaine, alcohol, and opioid use disorders. For the past 2 decades, he has been involved with clinical trials for these medications. And Dr. Campman will be sharing his experience and insights related to some of these medications tonight. So I'd love to welcome Dr. Campman.
Thank you for the nice introduction.
Yeah. Thank you for your great work. It's pretty easy to have a great introduction with a great doctor. So thank you. So Dr. Campman, we've heard, we'd love to shift a little bit the conversation from just the talk about prescribing opioids to this term opioid use disorder. A lot of us hear the word addiction and opioid addiction. Can you tell us, to start, what is opioid use disorder? Why is that a preferred term? Can you just give us a little bit of background before we dive into your work?
Okay. So, we use the term opioid use disorder now to reduce stigma as much as we can. And although I've never really considered addiction to be a stigmatizing word, it can be considered stigmatizing by some. So opioid use disorder is the preferred term. And also, just so everyone understands, opioids include street drugs like heroin and fentanyl, as well as prescription pain relievers like oxycodone, hydrocodone, codeine, morphine, tramadol. So opioid use disorder is a disease. And whenever I talk about it, I always like to start by talking about what it's not. And first of all, it's not a moral failing. And this is one of the most troublesome misconceptions about opioid use disorder, because it keeps people from coming to treatment. Psychiatry has done a pretty good job in reducing the stigma associated with depression and anxiety disorders, but there's still a lot of stigma attached to opioid use disorder. Another popular and damaging misconception is this idea that one can actually cure opioid use disorder in a 28-day rehab. This is a frustrating misconception for patients and their families when a patient relapses. It can also be a dangerous misconception for patients with opioid use disorder, because going to rehab and being discharged without a relapse prevention medicine often leads to overdose and all too often death. What opioid use disorder is a chronic brain disease, and it's controllable if not curable. What's hard for a lot of people to understand is why patients with opioid use disorder just can't stop. It seems simple. If heroin is ruining your life, don't do it. But in opioid use disorder, this clearly voluntary behavior of introducing a drug into your system turns into a largely involuntary behavior. Alan Leschner, who was a former director at the National Institute on Drug Abuse, used to like to call it the big switch. Patients with opioid use disorder lose control over the use of a drug due in large measure to changes in the brain. That's the big switch that makes drug use much less of a voluntary behavior. Okay, so what do opiates like heroin do in the brain? Well, first of all, drugs fundamentally alter our ability to experience pleasure. All drugs of abuse activate the pleasure center of the brain. That's why addicted individuals start to use them in the first place. Now, the pleasure center wasn't built into our brains just so we can enjoy drugs. It's built into the brains of all animals so that they do the things that are necessary to survive and reproduce. So food and sex, for example, are big stimulators of the pleasure center. Drugs hijack this natural and healthy system to reinforce drug use. Now, the problem with drugs like opioids is after repeated administration, the pleasure center stops responding as well as it did in the beginning. It takes more drug to get the same effect. So the drug user ends up taking more and more drugs to get high. And on top of this, normally pleasurable activities also result in less activation of this damaged pleasure center. And so other sources of pleasure and satisfaction are much less appealing, and continued drug use is further reinforced. We call this tolerance. Now, opioids also affect other parts of the brain beyond the pleasure center. Now, one of these other brain areas that's affected is called the locus ceruleus. Now, the locus ceruleus is the part of the brain responsible for maintaining important basic bodily functions, like keeping our hearts beating and keeping you breathing. Opioids lower activity in the locus ceruleus. In an opioid overdose, in fact, it's opioid deactivation of this part of the brain that causes patients to stop breathing, and sometimes they die. So when opioids are taken for a long time, the locus ceruleus itself tries to counteract this effect, these negative effects of opioids, by increasing its own activity, sort of keep things steady. But if opiates are abruptly stopped, this increased activity is suddenly unopposed, and patients feel this as withdrawal. So it's not pleasant, and I'll tell you, patients with opioid use disorder fear withdrawal and will do almost anything to avoid it. So we have tolerance, we have withdrawal, and probably the most important changes in the brain that affect addiction are changes associated with craving. Now, craving is a powerful, often overwhelming desire to use a drug. And in fact, most patients who relapse do it after withdrawal symptoms and tolerance have resolved. What causes relapse most often is craving, usually triggered by exposure to reminders of prior drug use. Memories of prior drug use are incredibly strong, and this is because the brain cells associated with these memories are altered. The chemical signal is magnified, and so when these memories get triggered by reminders of prior drug use, the signal is incredibly strong and the desire to use becomes overwhelming. So opioids, like heroin, cause changes in the brain resulting in tolerance, withdrawal, and craving, and these are actually the main targets for the medications that we've developed. That's a very long-winded answer to your short question. Sorry.
It was great. It was so informative. I actually, before we get to the medications, though, I did want to ask you a quick question about that you had told me when we spoke that there was a 3 to 5 year kind of window. Like if you were able to maintain sobriety for 3 to 5 years, then all of a sudden you're repairing your brain. Is that the time period when you talk about the craving and those memories that could become triggers? Is that the time period, like if you make it to that period, that those triggers will be less likely to be triggering? Can you just...
Yeah, that's what we understand from the research that we've done. We've looked at patients with opioid use disorder over time, treated with medications like methadone, and found that patients who were completely abstinent from opioids for 5 years or more likely to maintain that abstinence after they stopped the medicine than patients who stop the medicine sooner than that. So yes, craving never goes away completely, but it takes a long time for the craving to be reduced. It also takes a long time for patients to learn to make the life changes necessary to avoid these triggered reminders in the first place.
So let's talk about these medications that you've been instrumental in helping to develop, which is pretty amazing.
So right now we've got 3 medicines that work for the treatment of opioid use disorder: methadone, buprenorphine, and extended-release injectable naltrexone. And yes, I have participated in the development of buprenorphine and extended-release injectable naltrexone, done a lot of studies with those. So when I say these medicines work, what I mean is that patients with opioid use disorder who are treated with these medicines are less likely to relapse and are less likely to die from overdose. Specifically, relapse rates are reduced by about 50%, and rates of overdose death are reduced by much more than 50% in patients who are treated with these medicines. Now, what are these medicines? Buprenorphine and methadone are actually long-acting opioids themselves. And as long-acting opioids, they are much less likely to cause the euphoric response that heroin or other drugs can use. But what they do really effectively is take away withdrawal symptoms, reduce craving, and if you take these medicines, they'll actually block the high that you get from abused opioids. So those are those two, buprenorphine and methadone. And the other medicine is extended release injectable naltrexone. That's a once-a-month injection. And naltrexone is a little bit different. It's actually an opiate receptor blocker. So it sits on the opiate receptor, stops you very well from getting high from abused opiates, does a really nice job too in reducing craving, but it doesn't take away withdrawal symptoms like the other two medicines. So you have to have your withdrawal treated before you start. And again, just let me emphasize one thing. These medicines don't cure anything. What they allow is to give my patients time during which they're not in relapse, they're safe from overdose, and they can go about the important business of making the life changes necessary to support their sobriety.
Yeah, and we talked before, it was interesting. We talked before, you explained to me that the difference between which medication to choose is that the naltrexone, you would have to detox before you went on this medication. And because of that, it seems to be less desirable to some patients, but maybe more desirable long-term. Am I understanding that correctly, or?
Well, that's right. It's again, opiate dependent or patients with opioid use disorder really, really don't like withdrawal and fear it. So having them to have to go through that process is something that is a little bit of a turnoff for the use of naltrexone. But once they get on naltrexone, it works really, really well.
And, the use of the buprenorphine has been kind of controversial with people that believe, the family that I worked with, for example, on our upcoming film, had talked about having tried buprenorphine, but feeling like an abstinence model was really the only model for them because of the interest and intrigue in possibly abusing buprenorphine. So I don't know if you're seeing that as well, but can you talk to us about, about that piece, about the idea of abstinence versus using these medications? Mm-hmm. Who might abstinence be better for, if anyone, and why is buprenorphine or one of these other medications a better option?
All right. Well, first of all, just let me say, we spent a lot of years trying to treat opioid use disorder with counseling alone, and it just flat out doesn't work. Relapse rates after discharge from detoxification and inpatient rehabilitation programs approach 100%. And this is even in the very best of programs. And most of this relapse occurs within the first few weeks to a month of discharge. And not only that, but the risk of death from overdose actually increases after people go through detoxification. So methadone, buprenorphine, and extended release injectable naltrexone, help patients get and stay stable. As I said before, they buy time for my patients during which they're safe from overdose, they're free from relapse, and they can engage in recovery-based activities and make the life changes necessary to support the sobriety long-term. Now, are they going to be on these medicines forever? I hope not. But I want them to be on these medicines for as long as they need to be on them. So patients, and just as a last part of that statement, patients who don't want to be on a medicine that has an opiate agonist activity like buprenorphine or methadone are often much more comfortable on naltrexone, which is a complete opiate antagonist.
One of the it's interesting. One of the questions that had been put in from the community was, could people be on buprenorphine? And some people might know that as Suboxone, could people stay on that long term?
Yes, they can. People need to be on these medicines for as long as it takes for them to make the life changes necessary to support sobriety without them. I said that so many times to patients, it just slips off the tongue. So that's the truth, as long as it takes.
What other therapy components do you find to be super important when somebody is, whether it's using one of these medications or whether they're not? What other treatment models are there? What other pieces should families know about that they should consider, using at the same time or apart from?
And again, as I've said, these medicines don't cure a thing. What they do is buy time for people to get into recovery. And so what that looks like is individual. Everybody's different. Certain things in general, sure. In general, making life changes is important. There's avoiding people, places, and things associated with prior drug use is very important. I think getting treated for psychiatric and medical problems that go along with the opioid use disorder is important. Repairing family relationships can be important. Sometimes it can be something really basic, like finding a safe place to stay and enough food to eat. Therapy is definitely an important part of recovery, and it may involve 12-step groups like AA and NA, absolutely, or 12-step facilitation therapy, which is sort of traditional drug counseling. It may involve, some of the more modern types of therapy like cognitive behavioral therapy or motivational interviewing. There's just a lot of evidence-based therapies out there, and I really encourage my patients to take advantage of them, because remember, what we're talking about is making life changes. That's the recovery piece.
And then I know you've talked a lot about, obviously that opioid use disorder can impact so many people differently. We're looking at everybody as individuals here. So knowing that, you've talked to me a little bit about your work in the space of precision medicine. So can you talk about that, of how we could kind of maybe consider looking at this without a one-size-fits-all approach to using these medications?
Sure. So I said, these are really good medicines, but even as good as they are, only half the patients treated with, for example, buprenorphine are going to avoid relapse in the first year of treatment. So that means that more than half actually do relapse. So these things are far from perfect. And, we continue to work on ways to identify and improve the medicines we have and identify new ones. So one strategy is using genetics to target these medicines more effectively. I think I said at the beginning, maybe I didn't, but I'll say it right now. Addictive disorders run in families, that we know. And there's work going on right now to try to identify how genetics may play a role in treatment. So this is being done mainly by my colleagues, Henry Kranzler, Wade Berrettini, Rick Chris, to give them a shout out. And there are others in the department as well. And so we have some really interesting findings that identify very specific changes in genes, mainly coding for opiate receptors, that seem to predict who is going to respond well to methadone and who might respond well to buprenorphine. And so what we're currently involved in is something called the Million Veteran Program. That's the part of this that I got involved in, which is a study now that involves like over 600,000 veterans for whom we have genetics data and health record data that we can use, to confirm these early findings and hopefully expand on them.
Okay. Well, I know we have it there. I see the Q&A blowing up for more questions from you, so I'm excited for us to come back for our roundtable and talk a little bit more. But I'm excited also to find out, Dr. Campman was really talking to us about what happens when someone's ready to accept treatment for opioid use disorder. And I'm really excited to introduce Jean Marie Perrone, who's really exceptional. She's a professor in the Department of Emergency Medicine. She's also the director of Penn Medicine Center of Addiction Medicine and Policy. She served on task forces with the CDC and the FDA. She advocates for harm reduction and is a national leader in the efforts to address the opioid epidemic. So I'm excited for her to give us a little bit more about what's going on when people come into the ER, and also what are we seeing in Philadelphia right now. So Dr. Perrone, thank you so much for taking your time to join us tonight.
Thank you. Thank you so much for having me. This is such an important topic, and I think we've already all learned a lot about the medications and access. What we see in the emergency department, some of which Dr. Delgado explained, but over the past decade, we did shift our prescribing away from, too many opioids for the most part, trying to do this judiciously. But we're picking up the pieces of a group of people that accessed opioids that were left in the home or left over in general. And so there's this growing number of patients who, weren't opioid naive, got exposed to opioids maybe in a therapeutic way or via misuse, and developed opioid addiction. Many people in their 20s and 30s trace that experience back to therapeutic opioids. So as a clinician, I, watched people get, in my opinion, too many opioids. We started writing guidelines in 2010, but really I shifted about 5 years ago to trying to make people, trying to give people opportunities to get into treatment with experts like Kyle from the emergency department. So we now offer patients basically buprenorphine, access to buprenorphine from the emergency department, either immediately after an overdose or if they come in for a complication of opioid use disorder. So we don't we know that in that cycle of addiction that Dr. Campman was talking about, people struggle for food and shelter. They can't make appointments to get to the doctor, 4 days from now or 2 weeks from now. So if we have them, somewhere in the hospital system or even in the emergency department, we can directly start the medication and immediately connect them with a peer recovery support person or a substance use navigator and get them into care with somebody who can coach them along the way. But getting the stabilizing medications, as Dr. Campman mentioned, is critical. And we start those in the emergency department.
So I guess one of the questions that has to come up is, are we trading one problem for another? Is this more of a Band-Aid than it is a solution? And what's your perspective on that? What do you think about when someone's coming in and getting these medications kind of right off the bat?
That is a critical question to ask. And I think it's very, very easy to make that assumption. They are all opioid medications, so you are trading one drug for another. But the statistics that Dr. Campman just shared are exactly why we need these medications. You can't get a 50% reduction in overdose deaths by just not taking them or continuing to use heroin. When you get onto buprenorphine or methadone, you have a 50% reduction in deaths. Right now, the data from the emergency department says that if you came into the emergency department today, 2% risk of death in the next month. We don't have any diseases that we have a 2% risk of death in 30 days. So it's terrifying to even discharge these patients without initiating therapy or initiating Narcan. So we do prescribe Naloxone. This is, basically a Narcan intranasal adapter that just, somebody can apply to a friend or have on their hand. So we actually dispense this with our patients, and they're instructed in how to use it in case they're not ready for treatment, but they know that they can just walk into an ER 24/7 and get care. And that's a really important safety net that we've created for our patients in Philadelphia because the crisis has been so bad here.
So a lot of people hear those words harm reduction. And I know, we just touched on it when we said that you advocate for harm reduction. Can you just give us the picture of what is harm reduction?
Harm reduction, yeah. It's, it's kind of a mindset about meeting a patient where they are. So sometimes we'll go out in the community and, talk to patients who are in active substance use and just, sort of engage in conversation. What do you need today? Food, socks. What would get you to trust me as somebody who might visit you, every week or every month? So it's engaging in conversations and giving people what they need to use drugs safely. So syringe exchange, Prevention Point Philadelphia is really a legendary resource for our community. And through those alliances, they, reduce the risk of HIV, reduce the risk of hepatitis, saves the government tons of money, and eventually gets a lot more people into treatment by forming these alliances. So it's a really valuable mindset. I can understand the controversy over it, but it is a really important way of offering treatment to people who have maybe lost hope.
So when you talk about meeting people where they are post-overdose, and you talk about giving people some of these medications immediately that could kind of help them so you don't see them back in the ER shortly thereafter. When we're trying to do that, can you tell us a little bit more about, I know you've engaged in a clinical study about this. Can you tell us, what does that clinical study look like? How many days would somebody be given that medication for? What type of follow-up? So what does it look like basically if someone comes in to a Penn Medicine ER, has an overdose, and then engages in this clinical trial with you?
So the patients who come to the emergency department, I'll give you a perfect example. A patient came in by ambulance last Thursday night, in tears, vomiting, in withdrawal. She had been using Percocet. Nobody in her family knew that she had been using. She'd had escalating dosing, and she had been trying to quit for 2 days. So her withdrawal symptoms were pretty severe. I talked to her, I said, have you ever heard of Suboxone? She said that she had been buying Suboxone to stabilize her withdrawal symptoms, but really couldn't afford that anymore. And I said, I can start you on Suboxone right now. And she just looked at me like, a deer in the headlights. Oh my God, really? That's exactly what I need. And we have this, we can start her on Suboxone, which we did, but we're also doing a randomized controlled trial between either usual doses of Suboxone sublingual, meaning under the tongue, or an injectable medication that lasts 7 days and actually gives them 1 dose of Suboxone that lasts for a whole week. And then when they see their doctor in follow-up, they didn't have to worry about getting a prescription filled. They didn't have to be ambivalent about maybe tomorrow I won't take my Suboxone and I'll go back to using if my cravings got too bad. So as you're ramping up your dosing of Suboxone in that first week, these patients already have a full dose in them. So it really decreases we think it will decrease, we really don't know the results yet. We think it will decrease the early fallout that some people try Suboxone and then drop out compared to usual care. But this patient, 30 minutes later, she was laughing and joking and so grateful. I saw her a week later and she was doing absolutely great, grateful, sending us text messages. It's life-saving. And to get that 50% reduction in overdose deaths instead of the 2% risk of death, that's a life saved. And in the emergency department, that's what we're all about. So it feels good for us. It feels good for all of my providers, all of my colleagues who, took the special training in order to be able to prescribe Suboxone.
Yeah. And what are you seeing? I know you gave that as a snapshot of what happens in the ER, but what are you seeing right now in the ER? What is the climate in Philadelphia?
So the opioid use crisis has gotten worse. I think we saw a lot more deaths around COVID with isolation and loss of jobs, loss of connection to healthcare. So we definitely know that the numbers are getting worse, and preliminary data has supported that. But hoping, what I see, we have this prescription drug monitoring program where, when a patient comes in, I can see when their last opioid was or when their last Suboxone dose was. And so many people I see that are getting back into care now were stable until March 2020, and then, that was their last dose. So hopefully we're picking up the pieces and getting people back to where they need to be in a more stable place with, access to medications and treatment.
You also had mentioned to me about just so much of the overdoses that you're seeing being connected to fentanyl and not just with opioids.
Yeah, so that's a great point. So most of the opioid supply in Philadelphia is contaminated or adulterated with fentanyl. There's a lot of people who use just pills that they buy on the street, but even those pills are now pressed fentanyl tablets. So they might look like oxycodone, but they're actually still using fentanyl. And so fentanyl in heroin and fentanyl in these tablets is making the response to Suboxone a little bit different. However, we're also seeing fentanyl in cocaine. So we have, a large community of patients who have been using cocaine off and on for many years. All of a sudden, when there's fentanyl in cocaine, they have no opioid tolerance. And so those patients are overdosing, and they don't have Naloxone nearby, and they don't even recognize the symptoms or, have any training on that. So we are trying to do some outreach in the community to get Naloxone to groups of people that might be using cocaine and are unaware of an exposure to fentanyl. Thank you. I forgot about that. Really important.
Yeah. And is there anything else that you see as important that we should be considering or you're hoping will change related to policy and other research that's needed?
There's a lot of policy. Lowering barriers to buprenorphine is important. There is this 8-hour training that's required to prescribe buprenorphine, and that, is a big barrier. That's part of why this injectable medication was made and has this role specifically in the ED, is so that they don't need to have everyone in all the emergency departments around the country go through taking the 8-hour training. So lowering those barriers would be really important. Making sure insurance pays for either buprenorphine, or there's an injectable form of buprenorphine that lasts 30 days. And so some of our patients on our 7-day injection are being bridged to a 30-day injection. And that really gives people a lot of relief and less anxiety about taking their medication. But those have big insurance barriers as well. So lowering insurance barriers to treatment would be really important.
All right, thank you. Well, I'm super excited to be able to have all of our docs back on together. We'll have a bit of a roundtable in our last few minutes. Before we open it up to some questions in the Q&A, and I invite Cheryl in to help guide us through our Q&A, I would love to just remind everybody who's here that there will be a link. So if you didn't catch everything, or there were some of the trials or medications or research that's going on from any of our doctors, you'll be able to watch back the presentation. I also do want to thank all of our doctors for being here, just in case we run right up to questions. So thank you so much for sharing your expertise, sharing your viewpoints of what's going on in the community and in the area of opioid use disorder. And I'd also like to thank Penn Medicine for inviting everybody here and just sharing the work that they're doing. Obviously, this is something we need to work on as a community, so it will be great to find out what people can do. So while we're waiting for Cheryl to join us, maybe one of the questions we could pose to whomever would like to take it on the panel is what can someone who's watching do? It could feel like such a hopeless epidemic. Is there something that every individual, in addition to maybe joining the disposal proposal or asking their doctor if they're being judicious, in addition to asking these great questions about clinical trials that are available or the medications that are available, what can people do?
I mean, I think, are we muted? We're not muted. I think the most important message is that there's hope, there is treatment, and everybody knows some family who's suffering with a young adult. And I honestly think that, it has seemed like a hopeless disease from the public standpoint. And I think we should really emphasize these medications are really outstanding. They're better evidence than most of the other drugs we use for lots of things. So there's medications, there's resources, and there is hope. Even if you fail once, we should try again. It's not a one size fits all, but there should be hope offered to friends and family.
Great. Cheryl, do you want to help us guide through some of the questions in the chat?
Sure. There's so many. I apologize we won't be able to get to all of them, but I'll give you a couple. Here's one that I found interesting from Scott Burgess. Do you recommend not-for-profit groups like Conquering Life Prison and Recovery Ministry to people looking for help, or are there other nonprofits that you might recommend to people looking for help? And I assume that's really directed to patients coming through the ER.
I can say for the ER, we generally refer most of our patients to our primary care medicine doctors who have taken this on as part of primary care. Just like they treat high blood pressure, they treat this as just another medical problem, chronic disorder, just like Dr. Campman described it. So within that, some of them also have other mental health or society support resources. And then we have this wonderful peer support group that can also direct people to individual kind of strategies that work best. And a lot of that has to be, now that everything's virtual, it doesn't matter as much, but previously it had to be in your neighborhood so that you could actually go as frequently as you needed to go. So we had many resources.
Great. Along those lines, Andrew Wilson asked, does the University of Pennsylvania have a list of general practitioners that help patients with long-term addiction care? I think she's wondering, is there a list available somewhere? She said that she wants to find a GP that is understanding, and sadly, not all medical professionals are as understanding as this panel.
Sure. Well, the core group, the Center for Opioid Recovery and Engagement, has a website with phone numbers that you can call, and we will help you engage in treatment. And if we can't provide it here, we will help you find it elsewhere. So that's an important resource for people.
Thank you. There was another question, or actually there were a few questions, and Kyle, Dr. Campman, I think maybe you can address this one. There were a lot of questions about our other addiction disorders or use disorders such as alcohol or other drugs. Do they affect the brain the same way as opioids, or are there differences among those different crises or different problems?
Yeah, what I described were the changes in the brain, some are which are very specific to opioids, like opioid withdrawal, but all drugs of abuse cause tolerance, many cause withdrawal, and craving is absolutely universal among all the drugs of abuse, and generally by the same mechanism. But yeah, there's lots of similarities.
Thank you.
And someone was asking about Vivitrol, and so I think it's important for us to just kind of mention that was the Naltrexone that Dr. Campman was talking about. It was just Vivitrol's just a brand name for that.
Yeah, I'm sorry, I get used to using the generic names. I apologize for that. Vivitrol is extended release injectable naltrexone.
A lot to keep track of. Marissa Perone asked, can panelists discuss the role of overdose prevention sites as a harm reduction tool to save lives, which I think you did. But she asked, why don't we have more of these sites when we know they're somewhat successful?
Yeah, I think they are a challenge. Philadelphia, I think, is still working really hard to get the community and the government behind it. I think the public health department has been supportive. I think Prevention Point is, been putting a lot of resources towards it. I think overdose prevention sites are a really valuable tool and might have saved a lot of lives in COVID. But there are still a lot of political battles ahead. Maybe my understanding is the new administration is more supportive in their opioid priorities that they released recently.
Great. I know we're going a little over time, but I'd love to pop one more question in that got a lot of likes, so I think a lot of people are wondering about this. It's from an anonymous person, but he asks, my main question for tonight, my son almost died of opioid addiction in his 20s. After a long road of recovery, Suboxone saved his life. He has now been on this medicine for over 10 years. Is there a way to get him off this medicine, and shouldn't his doctor who is prescribing be helping with this?
Yes, there is a way to stop Suboxone gradually, appropriately, and yes, he should ask his doctor about this. Generally, I let my patients sort of give me the hint that when they think it's time, and if I agree with them that it's time, then we would start the reduction. It's a very gradual process. It's not something that you want to rush into, and it's not something you want to do very quickly. And you just need to monitor things, because remember, this is a chronic relapsing disease, and so coming off Suboxone does, pose some risk, although they may be fully acceptable risks after someone's been abstinent for a long time, but still a risk.
Thank you. Unfortunately, we're a few minutes past 6 o'clock, so I'll hand things back to you, Hallie, to close out, but hopefully we'll be able to address some of these other great questions in some future Insight series. We'd love to do more of these sessions and bring this information to everybody because it's clearly so important.
Yeah, so hopefully we just gave a little bit of the work that's being done by these great doctors and at Penn Medicine. Thank you so much for being here tonight. If you're struggling, our heart is with you. I'm so excited that Dr. Perone shared with us the message of hope and light, and that we know that we're in great care with these doctors and their hard efforts to try to heal our community.